I would like to thank Sages very much for the opportunity to present our scientific research. I hope everyone is staying safe and healthy. Today, I'll be presenting our study, which deals with managing therapeutic anticoagulation in bariatric surgery patients. These are our disclosures. Bariatric surgery has become a leading treatment for obesity and its related comorbid conditions. As a bariatric surgery has become more widely accepted as a frontline therapy, more patients are being offered this treatment for obesity, leading to a diverse patient population with a variety of underlying comorbid conditions. There are several conditions that obesity is linked to that require long-term treatment with therapeutic anticoagulation. These conditions include deep vein thrombosis, pulmonary embolism, arrhythmias, and heart failure, and that heart failure can generate arrhythmias or require ventricular assist devices. Our own analysis of the MBSA QIP database between 2015 and 2018 demonstrated that patients undergoing bariatric surgery while being treated with therapeutic anticoagulation are roughly 2.5 times more likely to experience a bleeding event. The question is, why is that? Is it related to their underlying comorbidities, an effect of being chronically anticoagulated? Are there differences in practices of management in these patients? Or are there differences in intraoperative interventions that result in higher bleeding rates? With our study, we hope to examine the third question here and use our institutional database to closely examine the perioperative management of therapeutic anticoagulation in hopes that we may be able to better identify best practices in management of these patients. The purpose of our study was to validate the assertion that these patients are at higher risk for bleeding using our institutional database. Our hypothesis was that these patients are at higher risk for bleeding, and through examining their perioperative management of medication, we hope to identify best practices that may give us more information as to why therapeutically anticoagulated patients are at higher risk. We are a major academic institution and performed 2,933 bariatric operations within our study period. Of these patients, 64 were chronically anticoagulated. To identify these patients, we searched for patients undergoing a primary bariatric operation who were taking one of a list of medications that could be used for chronic anticoagulation. Patients who were having revisional or planned open operations were excluded from this study. This is a chart demonstrating the indications for why our patients were on chronic anticoagulation. As you can see, VTE and AFib are the most common. Other indications included hereditary clotting disorders such as factor V Leiden, ventricular assist devices, previous PCI, and mechanical valves. This is a chart demonstrating medications used for these patients. Warfarin was the most common, followed by Xarelto, Plavix, Eliquis, Pradaxa, Arixtra, and heparin. This is another chart demonstrating the medication used and their mechanisms of action. This is a timeline of when medications were stopped prior to surgery. Medications were stopped as far out as 10 days prior to surgery or as little as 48 hours. Time to stop medication relied on the preference of the surgeon in consultation with involved medical specialists. This is a timeline of when medications were restarted after surgery. Heparin drips were restarted within hours of the end of the surgery. And these were our patients on ventricular assist devices. Of note, none of these patients that had ventricular assist devices suffered bleeding events, even though their medications were restarted very shortly after their operations. Other patients had their medications restarted on post-op day 0 between 8 and 12 hours after their surgery. But most patients had their anticoagulation restarted 24 to 48 hours after surgery, with some having it restarted 72 or more hours after surgery. In total, 64 patients were on anticoagulation. 40 patients underwent a sleeve gastrectomy, while 24 patients had a room-wide gastric bypass. 29 patients were bridged with a shorter-acting medication like Lovenox or heparin infusion in the case of our ventricular assist device patients. Average time medication was stopped prior to surgery was 4.7 plus or minus 1.7 days. And average time was restarted following surgery was 1.7 plus or minus 1.4 days. There were no thrombotic events that occurred during the course of the study. This is a chart that demonstrates the patient's underlying medical conditions in relation to bleeding outcomes. As you can see, there are no medical conditions that increase the likelihood of a patient having a bleeding event. Also, having multiple of these conditions did not predispose a patient to having a bleeding event. There were 4 patients that experienced bleeding, with 3 patients experienced bleeding inside the abdomen but outside the lumen of the bowel, while 1 patient experienced an intraluminal bleed. Of these patients, 2 had a sleeve gastrectomy and 2 had a bypass. 1 patient required a blood transfusion and reoperation, while the other 3 patients were managed conservatively with cessation of their anticoagulation. Of these conservatively managed patients, 2 required a transfusion. 1 patient received 1 unit of blood and 1 patient received 2 units of blood. In bleeding patients, their anticoagulation was stopped an average of 4.75 days prior to surgery, similar to those that did not experience bleeding. The patients who suffered bleeding had their anticoagulation restarted 1.25 days after surgery, compared to 1.67 in the non-bleeding group. The difference between these two groups was not significant. Length of stay was significantly impacted by bleeding events, as you can see. In the OR, all patients had staple line reinforcement of exposed staple lines, and estimated blood loss was not significantly different between these two groups. From our study, we conclude that bariatric surgery can safely be performed in patients on therapeutic anticoagulation. While bleeding rates are higher, many can be conservatively managed in the event of bleeding. There were no thrombotic complications, even in patients that had their anticoagulation stopped the earliest. Therapeutic bridging does not appear to contribute to bleeding events, and the most important factor in preventing bleeding is meticulous hemostasis in the OR. I would like to again thank SAGES for the opportunity to present our work, and I have listed our references here.